Atria of an experimental animal were superdistended by blood that resulted in decreased reabsorption of sodium and water in renal tubules. This can be explained by the influence of the following factor upon kidneys.
All right, so please give me a bigger screen. Let me explain something. So this is the right part of the atrium, left atrium, right ventricle, left ventricle, right? Now what happens is that whenever there are a lot of blood returning to the atria, they stretch it. And remember, the cardiac muscle are having specialized cells. Now, one is contractile muscle, okay, or contractile cell. We have the hormonal cell, okay. We have the excitable cell. Okay, so the contractile cell, we have the hormonal cells, and they all have their special functions. Okay, now the contractile cell is the myocardium proper. Okay, the cardiomyocyte, which helps in the contraction. Now, hormonal cells, example of those hormonal cells are those cells that secrete a hormone which we call the Atria Natriuretic peptide or hormone. So those cells, these hormonal cells, what happens is that they have a receptor which is called stretch receptors. So whenever whenever there is stretching of the atria wall, they tend to release this atria natriuretic peptide. And what is the function of this atria natriuretic peptide? Basically, what the atria natriuretic peptide does is that, okay, it undergoes series of reaction to increase excretion of sodium and water. Okay, sodium and water. Okay, sodium and water. Now, how does it do that? So normally I try to tell you how, and so that you appreciate it. First of all, you know, in what situation would the atria be stretched? In situations like congestive cardiac failure, okay? Congestive cardiac failure, which we call CCF, okay? Congestive cardiac failure. So what is happening is that there is a lot of blood returning to the heart, but the heart cannot pump the blood to general circulation. So it is like a lot of blood is being accumulated in the heart. So if there are a lot of blood returning to the heart, what will happen? There will be stretch in the atria, right? Some will be pumped through the pulmonary trunk and it will come into the left atria, and that one too will be stretched. And once those hormonal cells, which are sensitive to stretch of the atria, once they are stretched, they start producing the atria natriuretic peptide. And what they do is that basically they go to the kidney. Most of its function is in the kidney. Now, once they go to the kidney, you know, the functional unit of the kidney is what? The nephron. So in the nephron, you know, the loop of Henle. In the loop of Henle, what happens? In the loop of Henle, what happens is that here it is immersed in the medulla of the kidney. So in the kidney, we have the cortex and we have the medulla somewhere here. Okay, so you realize that the Bowman's capsule is at the cortex, and once you get to the medulla, that's where you have the loop of Henle. Now that place is highly concentrated because the kidney undergo what we call counterbalance excretion, and that counterbalance system mechanism. What happens is that as the fluid is coming down, or as the filtrate is coming down, there is a movement of electrolytes like sodium, okay? Those sodium and other stuff will move into the medulla, and as they are climbing, there will be reabsorption of water from that end. So a lot of sodium will be moving from the loop, from the descending limb, like sodium, okay, electrolyte like sodium, and the membrane, the channel that they pass through is called the endometrium sodium channel, okay? So sodium will have to move into the medulla, and as the filtrate is getting to this part, then because the sodium will be highly concentrated here, water will start moving, okay? Water will start moving into the medulla, and from there, it means that there will be reabsorption of water, a lot of reabsorption of water at this point, at the loop of Henle, okay? Now, there are certain drugs like diuretics which actually blocks the function of these endometrial, okay, endometrial sodium channels. Now, what happens is that when you release this atrial natriuretic peptide, it comes and blocks the endometrial sodium channels. And what does it do? Once it blocks it, it means there will not be absorption of sodium into the medulla. And in that case, it means sodium will still remain inside the tubule, right? And if sodium is still inside the tubule, will there be a concentration gradient that will allow water to move from the lower concentration to a higher concentration? No, so water too will not move. Do you understand it? So everything will come out, sodium plus water, okay, sodium plus water, and even potassium. Because the potassium channels that passes through, potassium channel which allow potassium to pass through into the medulla tree is blocked. However, another function, so first of all, they block what? Inner, or with what we call endometrial channels, endometrial sodium channels. So they block endometrial sodium channels. Two, what they do is that, okay, what they do is that, remember that we have the afferent arteriole and we have what? Afferent arteriole, right? So this afferent arteriole, what happens? If they dilate, what will happen? More blood will flow into the glomerulus. And once more blood flows into the glomerulus, hydrostatic pressure will increase and more fluid will be filtered. So it increases filtration, right? Now, what the atrial natriuretic peptide does is that it will bind to its receptors on the afferent arteriole and cause dilation of the afferent arteriole. So it will dilate what? Afferent arteriole. So once it dilates it, what will happen? More of the fluid will come here, and then more of blood will flow into the glomerulus and increase filtration, right? Apart from that, what does it do? It also inhibits the release of renin, okay? Once it inhibits the release of renin, what is going to happen? It means that renin, angiotensin, aldosterone system will be decreased, okay? Will be inhibited. So what will happen is that there will eventually be no angiotensin, which will cause vasoconstriction here, okay? And two, there will be no reabsorption of sodium and water at that distal convoluted tubules, okay? Because this is where it is at this point where the aldosterone will bind to, will go inside the cell, then regulate the sodium potassium pump, okay, to allow reabsorption of sodium and water and excretion of potassium. But once it inhibits the release of renin, this whole process will not occur. So sodium and water will not be reabsorbed and it will be allowed to be excreted. Why should this happen? Remember, in people suffering from congestive cardiac failure, okay, there is volume overload on the heart, okay? Now, volume overload on the heart means that there is a lot of venous returns which the heart cannot pump forward, okay? So how do we get rid of that? First of all, we need to find a way of depleting the volume, okay? We need to find a way of depleting the volume. And naturally, the heart secretes a hormone which helps in that process, okay? And the name of that hormone is atrial natriuretic peptide. So, in fact, their mechanisms are a lot. I just mentioned only these three. It blocks what? Endometrial sodium channels. It also dilates afferent arterioles. It also blocks what? Renin. So, it prevents renin, angiotensin, aldosterone system from working. Does anybody have any question? So in people who have congestive cardiac failure, naturally, this is how the body works to protect itself, okay? Now let's see the question and then answer it. So, atria of an experimental animal was superdistended by blood. That resulted in decreased reabsorption of sodium and water in the renal tubule. This can be explained by the influence of the following factor upon kidneys. And the answer is going to be natriuretic hormone, okay? Natriuretic hormone. Now let's move on to question number 122. Nanaya, please read that question for us.
A patient suffers from hepatocirrhosis. State the antitoxic liver function can be characterized by examination of the following substance excreted by urine.
So when we talk about antitoxic liver function, we are basically talking about detoxification process that occurs in the liver, right? Now, we all know that the liver detoxifies substances, right? But do we know how exactly the liver do that? Okay, let's try and get a basic understanding of how the liver detoxifies substances that may be harmful to our body, which we've ingested. Now, if you ingest any foreign substance which can be toxic in nature, we call those substances xenobiotics, right? Xenobiotics. So if you've taken a drug, if you've taken some food which contains some chemicals, those substances are all xenobiotics, right? Now, these xenobiotics or these toxic substances, okay, they first get to the liver, okay, because once you eat, what happens? Remember, you eat, food passes through your esophagus, it gets to your stomach, right? Just a little bit of anatomy. Then your duodenum, and in your duodenum we have what? Pancreas, right? And just here we have a spleen, right? We have a spleen here, okay? The spleen. Now, the duodenum goes down to give us jejunum, then it goes along to give us what? Ileum, right? Like that. And the ileum joins the large intestines at the cecum, okay? And at a point where we call ileocecal junction. Then in the cecum, the blunt end is given as the appendix. So it goes up as what? Ascending colon, then the transverse colon, okay? Then we have descending colon, and the rest, you know, sigmoid colon, then rectum, right? Now, last time we spoke about, so this is where the liver is. I'm trying to explain something simple here, but don't worry. Just as part of the class. So last time we spoke about the celiac branch supplying the foregut, and then a superior mesenteric supplying the midgut, blah, 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 and inferior supplying the hindgut, right? But we didn't speak about the venous system. However, let's see. There is one vein okay, draining the spleen, the GIT, okay, it drains the GIT, including the spleen, and once they drain everything, okay, even they will come together, okay, all the veins will come together to form a bigger vein, okay, which we call the portal vein. Now the portal vein and send those blood into the liver, okay. So the food that we're eating is rich, okay, it's rich in nutrients and other substances. So when you take medication, it will also be absorbed and pass through the portal vein, okay, and that portal vein is joined to the liver. Okay, so we'll explain what we call hepatic triad later, but that is where you understand how the portal vein eventually meet up with the hepatic artery, then form one connection to deliver blood to the hepatocyte. So eventually this portal vein is sending nutrients and plus the drug that you've taken into the liver, okay? And in the liver, this is what is going to happen. First of all, these xenobiotics, once it gets into the liver, it has to go through what we call phase 1, process of detoxification. So we are talking about process of detoxification. Okay? Now in the phase 1, this is what is going to happen. It needs a lot of vitamins, like vitamin B1, B2, B, all the B complexes, okay? And some vitamin C's like and we have glutathiones and stuff like that, okay? And they've called them flavonoids. Now, in the phase 1, it undergoes oxidation. Those xenobiotics will undergo oxidation. It will also undergo reduction, okay? Oxidation, reduction. Then it will undergo hydration as well. Now, once it undergoes all these processes, phase 1 has ended. It will form an intermediary product, which are usually the reactive metabolites. So sometimes those drugs that we take, it has to undergo this process and become very active. Some of them will undergo this process and most of them will become inactive. Now, the major important enzyme here that plays this role is the cytochrome P450. Okay, so when they ask you whether cytochrome P450 plays an important role in detoxification, is the phase 1. Okay, so cytochrome P450 plays an important role here. Then we'll form an intermediary product which is very reactive. Then it will enter into phase 2. Okay, in the phase 2, there is usually a process we call conjugation. Now remember, it's not only the, it is not only the food that we've ingested or maybe drugs that we've ingested that usually undergo detoxification. Even some of the products that we produce by ourselves undergoes this process. So in phase 2, conjugation will occur. Like, remember we talked about glucuronidation, where you have glucuronic acid binding to, okay. Malam, yes, please. Yes, sir. Thank you. Okay, sorry for that. So, glucuronidation, this is where glucuronic acid is added to substances. Like, you remember what product? What substance does conjugation of glucuronic acid helps in making it soluble? So phase 1 will make it highly reactive, right? The substance will be highly reactive. Now, it undergoes conjugation. An example of conjugation is glucuronidation. And we spoke about how indirect bilirubin is converted to direct bilirubin by the process of glucuronidation. Now there can be acylation with what? Amino acids. Amino acids like what? Glycine, taurine, and stuff like that. Now listen very well. Glycine, taurine, and other stuff. So this glycine and taurine helps in the formation of bile acid and stuff like that. So just for the purpose of these two, go and tell your mom. For the purpose of our discussion, I'll stop here with the detoxification process. Now, listen very well. There are some substances that, like if we are talking about this amino acid like this, glycine, should be produced in the liver. There are substances like sodium benzoate or benzoic acid, okay? Benzoic acid, which in the liver, at the point of conjugation, it adds glycine, okay, to form what we call hippuric acid. Hippuric acid. Now, this glycine here is supposed to be produced by the liver, but the benzoic acid, we can take it, okay, from outside. So, if we want to, but you see, this hippuric acid is excreted in urine. It's excreted in urine, okay? So, if we want to check the detoxification process or the detoxification function of the liver, okay, we know that benzoic acid, we can take it in. And once you take it in, it has to go through the detoxification process, phase 1 and phase 2. At phase 2, glycine will be added to it. Then the detoxification process will end. Because after phase 2, the product that has been formed becomes what? Water soluble. Okay? Water what? Soluble. And it can either be excreted in the feces or in urine. Okay? So, phase 1 will make the product highly reactive, and phase 2 will cause conjugation to make it water soluble, and it will then be excreted through feces or urine. So that is how even some most of the drugs work. So now look, in the benzoic, if the benzoic acid is taken in orally, it will be absorbed and pass through the portal vein, and in the portal vein, it will carry it to the liver, and then phase 1 and phase 2 process of detoxification will occur to form the water-soluble product called hippuric acid. And this hippuric acid is excreted in urine. So in the lab, if you want to check how the liver is working in terms of detoxification process, what you will do is that you give about 6 grams of the benzoic acid, right? And in ideal cases, this 6 grams to be absorbed by the liver and be converted to hippuric acid. Even if this process occurs, we expect to see about 4.5 grams of the benzoic acid in the hippuric acid, which is being excreted in the urine, if detoxification is occurring. But if detoxification is not occurring, the amount of benzoic acid seen in the hippuric acid found in the urine should be below 3 grams. Okay? It should be below 3 grams. So the hippuric acid is a hippuric acid test. It's a test done to check the detoxification function of the liver. Okay, so in the lab, you give the patient 6 grams of sodium benzoic acid in water, about 250 ml, and then that one you do it in the morning after 2 hours after the person has taken a light breakfast. Then you wait 4 hours time. You collect the person's urine over 4 hours. Okay. Then you check the content of benzoic acid in the urine. So if the content of benzoic acid in the urine is 4.5 and above, it means that the liver is detoxifying properly. But if it is below 3 grams, then it means the detoxification function of the liver has reduced. Does anybody have any question? So we spoke about the...
Dr. Mo.
Yes, sir.
Please, the last part, can you explain it again?
Which part? The benzoic...
That is the 6 grams, then that of the 3 grams of the hippuric acid that you talk about.
So I said that you take in 6 grams of this, benzoic acid.
Acid, yeah.
Okay,
Yeah.
with water. Okay, early in the morning after the person has 2 hours after light breakfast. Now this benzoic acid will be absorbed through the portal vein. Now in the liver, this benzoic acid will undergo phase 1 of the detoxification, and at the phase 2 of the detoxification, glycine will be added to the benzoic acid, right? Once glycine is added to the benzoic acid, the product that will be formed is called hippuric acid. Now this hippuric acid is water soluble because we said after phase 2, the products that are formed are water soluble, right? And either it is being excreted in feces or urine, but this hippuric acid is excreted in urine. So once you give this patient this 6 grams of benzoic acid, over the next 4 hours, you collect every urine that the person urinates. Then you check the content of benzoic acid in the hippuric acid found in the urine. They have a way of doing that. They will check the benzoic acid content, okay, in that hippuric acid found in the urine. And I'm saying that if the benzoic acid content in the urine, which contains that hippuric acid, is above 4.5 grams, then it means that the liver is actually detoxifying properly. That is why most of the benzoic acid were conjugated with glycine to form hippuric acid. Do you understand it?
Yes,
but
sir.
if the content of benzoic acid is 3 grams and low, then we say that the detoxification function of the liver has decreased. That is why the benzoic acid content in the urine, the hippuric acid found in the urine is low. Okay?
Oh, okay.
Okay. Is there any other question? So please project it and let's move on. Michelle, please read the next question. So the answer is going to be, please let's answer that one and move on, please. 1, 2, 2 again. Please, question number 1 to 2 again. Hello? Let's repeat question number 1 to 2 again, please. All right. So a patient suffers from hepatocirrhosis, right? So that's liver cirrhosis. State of antitoxic liver function can be characterized by examination of the following substance excreted by urine. And what we are going to check is the hippuric acid, okay? And we've explained how the test is done. Now, Michelle, please read question number 123.
Dietary intake of a 30-year-old nursing woman contains 1,000 mg of calcium, 1,300 mg of phosphorus, and 200 mg of iron per day. It is necessary to change contents of these mineral substances in the following way.
Okay, so this one, I'm not going to write anything on the board. You know, phosphorus helps in this thing, mineralization process of the bones. In a normal female adult who is not pregnant, okay, in a normal female adult, 1,300 milligrams of the phosphorus is enough, okay? But because if this woman becomes like pregnant and delivers and she's breastfeeding, okay, during that whole process, when she's pregnant, the phosphorus content 1,300 will not be enough for her. Why? Because the baby will also need some for what? For bone mineralization. When she is breastfeeding the child, some of those phosphorus should pass through the breast milk to the baby, okay? So you need to increase the content of the phosphorus. However, the rest are okay. Okay, because even the iron content, normally if you go to hospital, we also give you no supplement. Apart from that, we don't give you phosphorus supplement. So the one that you are taking in your food should be enough, okay? So here, the answer is going to be increase the phosphorus content. Does anybody have any question? If no, please let's move on. Gloria, please read question number 124 for us.
A 25-year-old patient was examined by a medical board. Examination revealed pathology of chest. Transverse dimensions were too small, and the sternum was strongly protruding. What chest height is it?
All right. So I'll let Obi show you a picture, okay? But normally we have a condition we call pectus carinatum and pectus excavatum. Now these are the chest appearance due to either a disease process or congenital malformations, okay? Most of the times when you see someone's chest either protruding out or protruding inside, it can be a disease process, okay? So when you're examining the chest, on inspection, you have to define how the chest looks like, okay? So with this patient, they are saying that if you look at the lateral diameter, okay? If you look at the lateral diameter, so let me just draw an example of somebody's chest here. I don't know whose chest, but it's somebody's chest. So this is somebody's chest, and they are saying that in the lateral diameter, the lateral diameter is reduced. However, if I'm drawing it from this angle, okay, from the angle of the lateral view, okay, the anterior posterior distance. So just imagine this is the sternum, okay? So the sternum looks something somehow like this. Obi, can you get me a picture of a patient with pectus carinatum?
Okay.
So realize that this part of the chest is protruding, okay? Now, when the chest looks like this, it looks like that of a pigeon, or we call it the keeled chest. Patients who usually have this, some of them are chronic asthmatics. Okay, so this patient may be having asthma in childhood, okay, and because of that, because of hyperventilation of the chest, it has led to, you know, in babies too, the bone is not completely grown, and it is not completely ossified also. So if you keep on having hyperventilation, it tends to change the shape of the sternum plus the ribs, okay? Another condition that leads to this is when someone is having rickets or vitamin D deficiency. Now, people with vitamin D deficiency, you know that vitamin D helps in the absorption of what? Calcium and phosphate from the intestines, right? Now, what is happening is that because of lack of calcium and phosphate, whenever the osteoblasts secrete, the osteoblasts are the cells that helps in the formation of bones, okay? So they will first secrete a ground substance called osteoid. Now this osteoid needs deposition of calcium plus phosphate, okay? What we call hydroxyapatite. But if there is no calcium and phosphate deposition, which we call them mineralization. So these together, we call it hydroxyapatite. And the process of depositing calcium and phosphate or calcium and carbonate in the osteoid is called mineralization. So if there is no vitamin D, okay, low vitamin D, it means there will be low what? Calcium and what? Phosphate. If there is low calcium and phosphate, osteoblasts will still secrete the ground substance called osteoid, but these substances will not be there to cause mineralization. And because of that, the bones will be weak. And if it is weak, okay, there will be what? Misalignment of the bone, and it can give you a protruded chest. okay, protrudes out. And when you see that kind of chest, we call it pigging chest or keeled chest. So, Obi, if you have a picture of the, yes, so the one which is going inside is called pectus excavatum. Just think of it like excavator. You know what excavator does? It creates a hole. So that is why we call it pectus excavatum. But the one that comes out is pectus carinatum. And the other name for pectus carinatum is pigging chest, or, you know, pigging. That bears that are found on the distant square, center square. So that's how the chest looks like, or we call it keel chest, okay? So you realize that in this situation, the anterior-posterior diameter increases, okay? The anterior-posterior diameter increases, and it can be as a result of chronic respiratory infection, or maybe some respiratory condition like asthma or rickets, okay? Or probably a child with some tumor of the parathyroid gland. Let's move on, please. So here they are saying that when the examination board did the medical examination, they revealed that the chest, the transverse dimension, okay, were too small, and the sternum was strongly protruding. So if the sternum is strongly protruding, what do you think of keeled chest, okay? In fact, these are all types of chest that once you are doing physical examination, you should describe how the chest looks like. So if you are saying barrel-shaped chest, you are thinking more of a patient who is having COPD, okay? So if funnel-shaped chest, funnel-shape is the same as what? Pectus what? Excavatum, because it's creating like a funnel, okay? And that one too, even rickets can lead to that condition. Please, let's move on to question number 125. Does anybody have any question with the 124? If not, let's move on. All right. So, Monica, can you please read question number 125 for us?
Okay. The question 125.
Yes, please.
Screen 124th question, sir.
Sorry, can't you see the question?
Yeah, now I can. A 50-year-old patient has been taking treatment thrice for the last 6 months because of fractures caused by domestic accidents. Microscopical examination of bone tissue revealed foci of lacunar resolution, gland cell granulomas in the tumor-like formations. This bone tissue was substituted by fibrous connective tissue. Examination revealed also adenoma of parathyroid gland and hypercalcemia. What is the most probable diagnosis?
All right. So, bigger screen, please. In the anterior part of our neck, okay, just below a cartilage, there is a gland over there. What's the name of this gland? What's the name of this gland?
Thyroid.
Thyroid gland. Thank you very much. So when you take this thyroid gland and you turn it, okay, you turn it, this is what is going. So it still looks like that butterfly, all right, okay, but then you are going to see behind it there are some two superior and two inferior glands in each lobe. Now these glands are called parathyroid because they are just around the thyroid gland. So we call it what? Parathyroid gland. Now the function of parathyroid gland is to, one, maintain the calcium level in blood. Okay, maintain what? Calcium level in blood. Now, what's the normal calcium level in blood? So keep one in mind, 2.5 millimole per liter, right? Is it 2.5 millimole per liter or 2.5 milli equivalent? But in millimole per liter, it might be 10. Okay, 10 millimole per liter. No, I think 2.5 milli equivalent. Okay, okay, thank you. Milli equivalent. Now, why should calcium be kept at this level? Because calcium has a lot of functions in the body. It helps in clotting. It helps in muscle contraction. It helps in conduction of impulses. It helps in so many things. It helps prevent overexcitation of neural cells. So it helps in bone strengthening, okay, mineralization. So calcium is actually having a whole lot of functions. So it should be maintained at an optimal level where it doesn't go too high or go too low. If it is low, we'll have problem. If it is too high, it is going to deposit in our intestines and even our kidneys and then cause calcification. So in our tissues, and it will harden those tissues, okay? It will increase our blood pressure, it will cause constipation, it will cause renal failure and stuff like that. So we don't want that. So the calcium level should be maintained at 10 millimole per liter or 2.5 milli equivalent. I don't know whether it is the SI unit is right, okay, but I'll check it and get back to you. Obi, can you check the normal level for me? So, the function of the parathyroid gland is that whenever...
No, normal level for which?
Calcium.
Calcium.
Blood. Yes. Whenever calcium level goes down, what happens? Parathyroid gland will be what? Stimulated. And they will release a hormone called parathyroid hormone. Okay? Now, there are two cells in the bone. Okay? So I'm trying to draw the bone here. All right. So this is the bone. There are two cells. We have the osteoblast. Osteoblast. Okay. And think of osteoblast as
2.2 to 2.6 millimole per liter.
So it is the millimole per liter, which is the, okay, so the normal level should be around 2.5 millimole per liter. Okay, I didn't want to get this thing wrong, the SI unit. So if you are using the milli equivalent, okay, the milli equivalent would have been 10. Okay, now come back to the bone. Now the bone, first of all, because mineralization occurs, and the bone becomes hardened. So bone becomes store of what? Calcium. The bone stores what? Calcium. All right? So whenever calcium level goes down, what happens? Parathyroid gland will release parathyroid hormone. That parathyroid hormone has to come to the bone, and the bone will now what? Release a lot of calcium. How? First of all, there are two cells in the bone. We have osteoblast and we have osteoclast. Okay? Osteo what? Clast. Now, think of the osteoblast as a positive cell which helps in the bone formation. And osteoclast as a negative cell which helps in bone what? Dissolving. Okay? Okay, so it just dissolves the bone. Okay? Once it dissolves it, it releases calcium. So it causes what? Demineralization of the bone. So this one causes bone formation. Okay, formation. And this one causes demineralization. So it dissolves the bone. Okay, demineralization or dissolution. Or demineralization of bone to release calcium. So whenever calcium level is down, it signals parathyroid gland. Parathyroid gland will release parathyroid hormone. Parathyroid hormone will first stimulate osteoblast, and osteoblast will stimulate osteoclast, so that osteoclast will start what? Dissolving the bone to release calcium. So once it releases the calcium, it goes back into the blood to correct the calcium level. Again, when calcium level in the blood is low, parathyroid gland will detect it, and it will release parathyroid hormone. Parathyroid hormone will stimulate osteoblast, and osteoblast will in turn stimulate osteoclast, and osteoclast will start dissolving. Okay? So that osteoblast will cause activation of osteoclast to start dissolving the bone to release what? Calcium. And then that calcium that is released goes back into the blood. All right. So once that happens, what happens? The calcium level comes back to normal. Now think of it this way. What if something continuously is not the lower, listen, is not the lower level of calcium, but rather a tumor, okay? A tumor of one of the parathyroid glands. And because it's a tumor, it keeps on, whether calcium level is low or high, it keeps on releasing parathyroid hormone. So if it keeps on releasing parathyroid hormone, what will happen? Parathyroid hormone will still come to osteoblast to stimulate it. Then osteoblast will again activate osteoclast, and osteoclast will keep on what? Dissolving the bone to release more calcium. So the calcium that is releasing, it will be giving more than normal. Okay, so we'll have high calcium level in the blood, okay? Hypercalcemia. We don't want this because this condition is bad, okay? One, what is going to happen is that because there is excess release of what? Parathyroid hormone, excess dissolution of the bone is occurring. And excess dissolution of the bone means that the bone will become weak and it will start what? Breaking, okay? Or it will be very soft. Then what is going to happen is that the calcium that is released will stay in the blood, and it will cause the calcium level in the blood to go high. And in that case, what is also going to happen? It will deposit in the GI tract, in our vessels, in our renal tubules, and in our vessels, it will cause high blood pressure. GI tract, it will cause constipation. Then in our tubules, it can cause what? Renal. It can calcify it can even calcify in our renal tubules to form what? Kidney stones, and it can also cause damage to the tubules, okay? To lead to renal failure. So, in a situation whereby there is fracture, we can say that this fracture is as a result of what? Parathyroid hormone. So, in that case, we say that this kind of fracture or weakness of the bone is called parathyroid osteodystrophy. Okay, osteo what? Dystrophy. So what do we say? We are saying that it's not good for the parathyroid hormone to keep on releasing, parathyroid gland to keep on releasing parathyroid hormone. Because if that happens, our bones will be affected, and the excess calcium in our blood will deposit in our GIT, the vessels, and then the kidneys, and it will cause more problem. So let's read the question again and answer it. And the type of bone problem is called parathyroid osteodystrophy. Please, the question. Please, the question, please. Okay. You've gone too much. Oh. We are in 120 something. 120. Was it 120?
125.
125.
Okay. Does anybody have any question here? So what do you take home from here? First of all,
I went to the wrong side. Sorry.
No problem. So first of all, what we've discussed so far, the function of parathyroid gland and the function of parathyroid hormone, the normal level of calcium, the excess production of parathyroid hormone and its consequences, okay? So we are talking about a 50-year-old man who was taking 3 times for the last 6 months because of fracture caused by domestic accident. Microscopical examination of, okay. Right. Okay, so microscopical examination of a bony tissue revealed a focal of what? Lacunar resolution, giant cell granulomas in the tumor-like formation cyst. So that giant cell, this in granulomas, okay? Those osteoclast cells, they are just some big cells. In fact, they are small cells which come together to form one big cell, okay? So bony tissue was substituted by fibrous connective tissue. Why? Because there was no mineralization. Because the osteoclast has demineralized the bone. So it is left with only the osteoid and the what do we call it? Collagen fibers. Good. So bony tissue was substituted by fibrous connective tissue. Examination revealed also adenoma of what? Parathyroid gland and hypercalcemia. Now we know why hypercalcemia, right? What is the most probable diagnosis? And the answer is going to be what? Parathyroid osteodystrophy. Hope there is no question. So let's move on. So question number 126. Daniela, please read that question for us.
A young man who entered a production department where it strongly smelled of paint and vanishes had a bronchospasm. This reflex was caused by irritation of the pipillary receptors.
All right. So normally in our GI tract, the mucous membrane, there are some receptors, okay? And these receptors, their function is usually to stimulate cough reflex, okay? But somehow, they're able to stimulate so much that they cause bronchospasm. This is what is happening. Now, this is our trachea divided into the bronchus. Now, it is within this trachea that we found receptors in the posterior wall, which is for irritants, okay? Now, these irritant receptors, so when you inhale some fumes or maybe some strong scent, okay, they irritate or they stimulate the irritant receptor. The irritant receptor. Now, these irritant receptors, like I said, they are found on the trachea. Ideally, what they are supposed to do is that they are receptors for the recurrent laryngeal nerve. Okay, so the laryngeal nerve is a branch of what? It's a branch of what? Vagus, right? Vagus nerve. So this information will be sent to the medulla. Okay, so this is our midbrain, pons, medulla, then we have the spinal cord. So these irritant fibers, okay, or receptors will stimulate the laryngeal nerve, which is a branch of cranial nerve 10, vagus. Then that information, this is the afferent pathway. This afferent pathway will be sent to the medulla. And then there will be what? Descending fibers, which is the efferent pathway. This efferent pathway, some will be supplied to the glottis, okay? And some will go to the intercostal muscles. Some will go to the diaphragm. What do? They allow you to cough. But now pay attention very well. But somehow, they are able to stimulate the vagus nerve so much that, okay, so much that most of those the bronchus and the bronchioles, okay, they also have receptors for acetylcholine, okay? So they stimulate it so much that there is overflow of that activation of the vagus nerve, that will cause vasoconstriction. Bronchoconstriction. Okay? Ideally, they are supposed to stimulate only cough, right? They are supposed to stimulate only cough. But whenever these irritant receptors are stimulated so much, okay, then they can cause bronchoconstriction, especially in patients who are asthmatics. Okay? Especially in patients who are asthmatics. So these same irritant receptors, during extreme cold weather, they are stimulated. And once they are stimulated, they also stimulate the vagus so much that bronchoconstriction can occur. That explains why the asthmatics can get attacked during extreme cold weather. And when they are exercising too. So when the trachea becomes dry, they are stimulated as well. Okay? So during extreme cold weather, during excessive exercise, and also during what? Pungent smells or pungent odors, pungent scents, okay? They are stimulated. So the stimulation of the irritant receptors, in ideal case, is to stimulate the cough reflex. But sometimes the vagus is stimulated so much that bronchoconstriction occurs. Does anybody have any problem here? Okay, if not, let's move on, please. So there are some other receptors that they've mentioned here. In appropriate time, I'll give you explanation to all of them, okay? All right. So the answer is going to be what? Irritant receptors. Question number 127. Millicent, please read that question for us.
Okay. An isolated muscle fiber is under examination. It was established that the threshold of the stimulation force became significantly lower. What is the cause of this phenomenon?
So let's go back to membrane physiology, okay? Mommy is sleeping, that's why what? So let's go back to membrane physiology. Now we are going to talk about action potential, okay? Action what? Potential. So let me make it AP. Now, in a cell, okay, in a cell, there are more positive ions outside and less positive ions inside, right? So sodium is more outside, calcium is usually more outside as well. Okay, so just like that. And inside there is potassium, which is more, but the inside of the cell, they're comparing the number of potassium in here to the positive ions in here to the positive ions out. In here is very low. So inside the cell is more negative, right? So most of the times on the membrane of the cell, there is a voltage, okay? That voltage is what we call the resting membrane potential. Resting membrane potential. Membrane potential. So from now, I'll use RMP for resting membrane potential. And usually some cells, their resting membrane potential is -90. Some are what? Around -70. Now let's see. Whenever this cell, assuming this cell is a neural cell, okay? So let me draw it to look like a neural cell, right? So assuming this cell is a neural cell, okay? Assuming they are neural cells. Like that. So neural cells, they have what? Dendrites. They have the cell body like that. And they have the axon lobe. That is where sometimes neurotransmitters are released. So let's say the inside is what? More negative. Outside is more positive, right? So for action potential to occur, what is happening is that more positive ions should move inside to make the inside more positive. Okay? So the inside here should be positive by the movement of our positive ions in here. Now, once the positivity reaches some level, then I'm going to explain everything now. So let's take, for instance, you've been touched, right? When I start pinching you, when I touch you, you feel that I've touched you. But here, in this case, I want to stimulate a pain fiber, okay? When I touch you, you feel that I've touched you, but you don't feel pain, right? But if I want to stimulate the pain fiber, what do I have to do? I have to keep on increasing the intensity of my pinch, okay? Now, once I start increasing the intensity of the pinch, this is what is going to happen. So we are talking about a neural cell. So let me draw a bigger cell so that it will be more clearer. So we already know that the outside of the cell is more positive, inside is more negative. Cells do have receptors, and what they do is that they receive impulses, okay? They receive impulses either by mechanical or chemical or means, okay? So some of the receptors are even channels with only receptors on them, okay? So some channels with receptors on them. So just assuming that the pain receptor in our skin, okay, the receptor, listen, the receptor is usually different from the cell. There are some receptors under our skin which take those information and then tend to stimulate the fiber. But I'm trying to explain it in such a way that you understand exactly what is going on. So the receptor will be somewhere here, right? And that receptor is having its connection to this particular ion channel. So the more I touch this receptor, it doesn't send any information. Sorry, once I touch it lightly, it doesn't send any information. But once I increase the intensity, okay, this receptor is then stimulated to release some chemicals here. Now, once these chemicals are released, okay, what happens? This channel here, assuming it is a calcium channel, okay, once this pain receptor or nociceptor releases that chemical neurotransmitter here, it opens this calcium channel and a little bit of calcium will come in. So for instance, some of the calcium, so let's say this cell, the resting membrane potential is, let's say, minus 70, right? So more of the calcium will start coming in as so long as this neurotransmitter has bound. So let's say 20 of the positive calcium has come inside, or let's say 10. 10 means 20, right? So it will lead to 20 positive ions. So the inside of the resting membrane potential, because 20 positives are moving, it will change what? Minus 50. Now let's just put the resting membrane potential here as minus 90. Once the calcium, 20 of it comes inside, it means that now the resting membrane potential moves towards what? Minus 70, right? Minus 70, sorry. Minus 50. Now listen and listen very well. Whenever I touch this one, it will release some neurotransmitter here, which will allow some calcium to come in. Now, at this minus 50, there is something that is going to happen. First of all, this minus 70 is what we call resting membrane potential. At this minus 50, we call it threshold potential. Okay? Threshold potential. Now, once the calcium, there are other channels on the membrane, okay? We call them voltage-gated channels. Okay, voltage-gated channels. Once you reach to the threshold potential, automatically, it means that once you reach to minus 50, automatically all these channels will also open. Okay, so sometimes it may be calcium here, it may not be calcium, right? So if these ones open, sodium or any positive ions may come inside. Okay, so a lot of them, sodium channels. Okay, so these ones are called voltage gated channels, which will allow more positive ions to come in. Now, in fact, the positivity that is coming in, it will be somewhere around maybe 90 positive, 90 plus, right? Or maybe 70 plus. And because it reaches to the 70 plus, what will happen? It will allow, there will be a spike. First of all, listen, positivity came in, and it moved it slightly to the resting threshold potential. Now, because it has gotten to threshold potential, more positivity will come in, and because of that, it will move the resting membrane potential of the cell from the negativities to the positivities. Okay, so maybe to positive 40. Okay, now at this level, some theories say that at that level, the positivity in here is equal to the positivity out. So no net movement can occur. So at that point, this is what is going to happen. Listen very well. These channels will close. I'm just explaining it in simple terms. These channels, these voltage gated channels will close. Remember, this one too would have closed already because you've pinched already. Now, at this point, at the class 40, these channels will close. And what is going to happen? Potassium channel will open. Potassium channels will open. And more potassium will start leaving the cell. Okay? Now, remember, potassium is positively charged. So once potassium starts leaving the cell will start moving towards negativity. So whenever one potassium leaves, will move to what? Plus 39, then downwards. So the more they leave, it starts declining. Okay? It starts declining. In fact, a lot of the potassium will leave up to a point where it will even, the inside will even be more negative than the minus 70. Probably it gets to minus 90. Okay? Then once it gets to minus 90, there is an an enzyme which we call the sodium potassium pump. Okay, or sodium potassium ATPase. Now this sodium potassium ATPase will be activated. And what does it do? It will pump 3 sodium out. Why? Because sodium was the one which rushed in a lot. Okay, so this sodium will be pumped out. So 3 sodium out. Okay, then what will it do? It will pump 2 potassium in. Okay, 2 potassium in. So remember that potassium started leaving whilst the potential got to plus 40. So whilst the potassium was leaving, the potential started declining again. And even it declined down to minus 90. So once it got to minus 90, there was activation of sodium potassium pump. And that sodium potassium pump is pumping 3 sodium out, 2 potassium in. So what is going to happen? So more positivity will leave, then only few positivity will come in. So in actual sense, there is going to be a net loss of what? 1 positivity outside the cell. So because of that, it will bring it back to the resting membrane potential again. Then once it brings it back to the resting membrane potential, this cell can undergo that process of what? Activation. Please pay attention. Now, first, the cell was at minus 70. And once you reach to minus 50, there will be opening of voltage-gated channels. Then voltage-gated channels will allow more sodium to come in. Then once the sodium comes in, there will be a spike in the on the graph because there is more positivity. So it will move it to the positive side. But once it gets to, let's say, plus 40, it will start declining because by then these voltage-gated channels will be closed, whilst potassium channel will be open, and potassium will start leaving the cell. So the potential will start declining again towards the negativity. And in fact, it will even decline downwards, even to minus 90. Then, once it reaches minus 90, sodium-potassium pump will be activated to pump 3 sodium out, 2 potassium in, to bring it back to the resting membrane potential. Now, let's learn something important here concerning our question. So it means that if maybe you touch the person, okay, and only 10 positivity comes in. So from minus 70, it will have moved to what? Minus 60. That is not up to this thing, minus 50. So action potential will not be generated. So the action potential is when these voltage-gated channels are open and there is what? Spike in the impulse, and then there will also be gradual declining of the distance, the impulse. But our action potential allows, once it spikes to this level, it allows adjacent cells to also receive such positivity so that that positivity will keep on going while the preceding membrane will go through this process. Okay, so that one I will not explain it today, but listen. I said, assuming only plus 10 had come in, we would have moved to minus 60. We would not gotten to minus 50, which is the threshold potential. We need to get to the minus 50 in order to allow these voltage-gated channels to open. But once we didn't get there, these voltage-gated channels will keep on closing. Ideally, in the initial form, they were closed. But once we get to minus 50, they open to allow more sodium to come in. But once we don't get to the minus 50 and they're still around minus 70, minus 60, they will not open. Okay? So what happens? This action potential have a rule that we call all or none. So it's either you get to the threshold potential or whatever positivity that you bring in will not be used to generate action potential. So even it can even be up to 19, plus 19, and still action potential will not be generated. But assuming that on this same cell, okay, on this same cell, listen, on this same cell, assuming because of something, there is already a way of bringing in some positivity, okay, like plus 10. Plus 10 has already come in, okay? So the cell will be, the resting membrane potential ideally is minus 70. But because some positivity has already found its way into the cell, now the resting membrane potential will move to what? Minus 60. We have not reached the threshold potential where it will allow the voltage-gated channels to open. But the resting membrane potential is still at what? Minus 60. So in that case, if I'm pinching you, first, if I have to pinch you so hard before the 20 will come in, now I don't have to pinch you that hard. With a little pinch, if 10 comes in, 10 plus that 10 that already exists will allow what? Will allow us to reach to what? The threshold potential, and then action potential will be generated. Please, do you understand it? So listen. Whenever there is opening of some calcium channel on the membrane due to whatever process, it makes the cell more excitable, okay? More excitable. So the ideal resting membrane potential is minus 70. But because the cell has already gained some positivity, the cell, we say that the cell is now excitable. So now you don't need plus 20 to reach threshold potential, but rather you need what? Plus 10, because already there is what? An already existing plus 10 in the cell. Okay? So this is the resting, this is the action potential graph. Once you are climbing, we call it what? Depolarization. Depolarization. Okay? But when the potassium starts leaving and you are coming back to the resting membrane potential, we call it repolarization. Okay? Now, once it goes through repolarization and even bypass the resting membrane potential, we call it hyper. So at this level where it has bypassed the resting membrane potential, we call it hyperpolarization. So what does that mean? What it means is that in the hyperpolarization, if resting membrane potential, we needed 20 plus 20 to reach action potential. In the hyperpolarization, how many do we need? Minus 90. Before we get to minus 50, that would be what? Plus 40. Please, I hope you are following, because these things are very important. This is the main cell physiology, membrane physiology you should understand. So in hyperpolarization, it means that it is very difficult for the cell to generate an impulse. But if you are addressing membrane potential, it is at the normal level where the cell will generate an impulse. But if by some means, some possibility, okay, maybe some calcium channel has opened and some calcium is trickling in small, and it has already moved from resting membrane potential, but not reaching threshold potential, but in between the level of resting membrane potential and threshold potential, like minus 60, then we say the cell has become what? Excited, or it has been excitable. Now, in that case, it means that you need only small amounts of the voltage, like plus 10, to just create action potential. Okay? All right. So there is something we call refractory period. Now, during the climbing, which is depolarization, and during the repolarization, at this point, assuming I still keep on pinching you, new action potential will not be generated. And during that time, no matter the stimulation, no new action potential will be generated. So we call that period, what do we call that period? Refractory period. But you see, during the climbing, we call it absolute refractory period, absolute. And during the declining, we call it relative. Why? Because during the repolarization period, if the intensity of the stimulation is so high, it can cause generation of a new action potential. All right? So during that period, during the repolarization period, exactly at the hyperpolarization level, when the intensity is so high, like I said, if it is like plus 40, you know, at the hyperpolarization, we've reached minus 90. The threshold potential should be at minus 50. So if the threshold, the intensity of the stimuli can bring in about 40 positive ions, okay, it means that it can move it from hyperpolarization to what? Threshold potential, and new action potential will be generated. So that is why we call the repolarization period or the hyperpolarization period relative refractory period. Okay, so we have the absolute refractory period. At the absolute, it doesn't matter the strength or the intensity of the distance. The stimuli, no new action potential will be generated. Does anybody have any questions? So in the question that they asked, let's read the question and answer it. Maybe I might go. So they said an isolated muscle fiber is under examination. It was established that the threshold of stimulation force became significantly lower. What is the cause of this phenomenon? So like I said, now that threshold potential, okay, at the threshold potential, in an ideal case, if it is minus, the resting membrane potential is minus 70, and there has been influx of about 10 of calcium channels, then it means that you don't need to stimulate this cell so much to reach to the threshold potential. So now the threshold potential will be lower, okay? So the threshold will be like only 10 positivity has to come in. So the answer is going to be what? Activation of what? Sodium channels of membrane. So I use calcium here. It doesn't matter. It can be calcium, it can be what? Sodium, okay? Does anybody have any question?
No.
I needed to explain everything in order for you to get a clearer picture of what is happening. If anybody have any question, please ask now, because I may not go over it into details like I've done today. All right. So let's move on to question number 128. Daphne, please read that question for us. Is Daphne around? If she's not around, then please, Priscilla, can you please read that question?
When skin surface was treated with a certain preparation, its antiseptic properties are provided by atomic oxygen that is formed in the presence of organic substance. What preparation was applied?
So when you send potassium permanganate into the cell, it is converted to some of these free radicals that can, so normally in the bacterial cell, okay, once this in potassium permanganate passes through their membrane and gets inside the cell, they are converted to what? Free radicals. And what happens is that they cause lysis of the cell, because these free radicals, what do? They steal an electron from the bond, okay? So potassium permanganate. So later, when we meet some questions, then I will explain into details what free radicals does to our cells, okay? So during the oxidation process, what happens, okay? Why we also need antioxidant. But when you give potassium permanganate to the patient, when you apply it, what happens is that they absorb into the bacterial cells and they are converted to these free radicals, and they cause lysis of the cell. So the answer is potassium permanganate. Does anybody have any questions? Else, let's move on. Ruth, please, you read question number 129 for us. 129. Is Ruth around?
Let me read it, Dr. Mo.
Okay, please, you can read it.
Okay, that is 129.
Yes, please.
Examination of a patient suffering from cancer of urinary bladder revealed high rate of serotonin and hydroxyntanic acid. It is caused by excess of the following amino acids in the organism.
So you remember the decarboxylation process, right? And we said this decarboxylation, what vitamin is needed as a coenzyme for the the decarboxylase enzyme? Vitamin what? D what? B6, thank you.
6.
And the active form is called
Pyridoxal
phosphate, pyridoxal phosphate, okay? So, tryptophan undergoes the process of decarboxylation, okay, and forms serotonin. As simple as that, okay? Tryptophan undergoes decarboxylation to form serotonin. What again? Histidine undergoes decarboxylation process to form what? Histamine, histidine. Okay, these are amino acids that undergoes decarboxylation process. Glutamate undergoes decarboxylation to form what? To form what? GABA.
GABA.
Good. Tyrosine will first undergo hydroxylation to form L-dopa. Okay? And L-dopa will undergo decarboxylation to form what? Dopamine. Okay? So you need to know the amino acids, the decarboxylation process that they undergo, and what neurotransmitter do they form, okay? So if you want to produce tyrosine, first, for tyrosine, it doesn't undergo straight decarboxylation. The first undergo hydroxylation to form L-dopa, and from L-dopa to what? Dopamine. From L-dopa to dopamine, that is where the decarboxylation process occurs. Glutamate undergoes, glutamate acid, undergo decarboxylation process to form what? GABA. Histidine undergo decarboxylation to form what? Histamine. Okay, so you need to know these ones. Tryptophan undergoes decarboxylation to form serotonin. All right, so let's move on to the next question. All right, so Afram, please read question number 130 for us.
Okay. A man was intoxicated with mushrooms. They contain muscarine that stimulates muscarinic cholinereceptors. What symptoms signalize intoxication with inedible mushrooms?
Okay, so they said what? The mushroom contains what? Muscarine, right? That muscarine we have, is it in the parasympathetic that we have muscarinic receptor? Right? Parasympathetic, right? Parasympathetic. So let's go to the eye. Now look at something. So I'll draw the eye like this. All right. Now this is the eye. This is the cornea. Now this is the what? Ciliary body. And this one becomes what? This one becomes what? The iris, right?
Iris.
Then the ciliary body is having some suspensory ligament, or what they call zonules. Then it suspends the lens. This area is called what? This area, this small hole here, is called what?
Pupil.
People, good. These ones are the what? The iris. Now, the iris, first of all, if they ask of somebody's eye color, okay, it's the iris which determines somebody's eye color. So if your eye colors are blue, it means that you have less melanocytes over there. So the iris is giving you a different eye color. So assuming you are looking at the person's eye like this, you see what? This black, for my eye, you see it to be black or brown, okay? specifically it's brown. So this small hole is called pupil, right? Now, the iris is this structure, and that is where it is pigmented to give you the color. Now, the iris controls the size of the pupil. Okay? It controls the size of the what? The pupil. So that you can view far objects and near objects also. Okay? So when I'm looking at far objects, what should happen? The pupil should dilate, right? Then I can see object from a distance, right? When I'm in a dim light area, what should happen? The pupil should also dilate, okay? So that small amount of light will enter, right? Now listen. So these people, in terms of light, when you are in a dim light, the pupil should what? Dilate. So that small light should come inside, right? And when you are in a bright light area, the pupil should constrict. Or when we throw a light on your eye, the pupil should constrict. There are two groups of muscles here in the iris, okay? Now remember, it is the membrane of the ciliary body that produces the vitreous humor, okay? But in the iris, there are two groups of muscles. Now these two groups of muscles, we have the Pipillary Sphincter. Let me use a black pen. Pipillary Sphincter. Okay, and we have the pupillary dilator. Okay, dilator. The pupillary sphincter can also be called the constrictor. Okay, so when you are in a dim light, okay, when the light is dim, your pupil will dilate. It is the function of the pupillary dilator to cause that. Okay, so the pupillary dilator are the ones that stretch to the periphery of the iris. These ones. So I'll use D for that. These thin lines, okay, they are the pupillary dilator. Okay, these thin ones, the one that I'm labeling with the black, they are the pupillary dilators. So what they do is that they constrict during dim light. In dim light, they constrict, and they constrict outwards. Okay, so as they move outwards, they move alongside. Outwards, and the pupil will be what? Wider, so it will dilate the pupil. Now, you see this red muscle surrounding the opening. That is what we call the pupillary sphincter or the constrictor. So the pupillary sphincter, what they do is that once you are in a bright light, what happens is that they constrict. So they constrict and they constrict inwards. Okay? While the dilator constricts outwards, this sphincter constricts inwards and narrows the opening. There are two different receptors on them. On the pupillary dilator, there is alpha-1 receptor. Alpha-1 receptor. And once you see alpha-1, it means that they respond to what? Adrenaline. Because alpha receptors and beta receptors are what? Adrenergic receptors. On the pupillary sphincter, there is muscarinic 3 receptor. So it means in the sphincter, they respond to what? Acetylcholine, because they are cholinergic receptors, okay? They respond to what? Acetylcholine. So it means that it is being supplied with what? Parasympathetic fibers. Specifically, this is what is happening. When the person ate the mushroom, okay? When the person ate the mushroom, what happened was that there was increase in muscarinic. And you know, the muscarinic receptors, first of all, the cholinergic receptors, okay? the receptors that respond to acetylcholine, or what we call acetylcholine receptors, they are called cholinergic receptors. We have two types. We have the nicotinic receptors, and we have the muscarinic receptors. Nicotinic receptors, because they respond to what we call nicotine. Okay, nicotine found in cigarettes. Okay, and this muscarinic is found in these mushrooms that we are talking about. So it means that this muscarine can stimulate these cholinergic receptors found on the pipillary constrictor. Okay, so once they stimulate it, they cause what? The pupils to undergo a process we call meiosis. So the people will be constricted. Okay, meiosis is the same as what? Pupil constriction. Okay, so because the person ate a lot of mushroom containing muscarine, those muscarine were able to stimulate that M3 receptor found on the pipillary sphincter here. Okay, and that is the reason why it is causing what? Meiosis. Meiosis is the same as pipillary constriction. But assuming they had said that the person was stressed, or maybe was given an adrenaline shot, because these dilators are having alpha-1 receptor, they respond to what? Adrenaline, right? And they would have what? Dilated. So that would have been mydriasis. Okay, mydriasis. So dilated people. So you should understand what mydriasis means and what meiosis means. So once you stimulate parasympathetic, there will be what? Meiosis. Once you stimulate sympathetic, there will be mydriasis. Okay? Another way of stimulating sympathetic is to block parasympathetic. Do you understand it? So if I give you cholinergic blocker, you get mydriasis. Like atropine. If I give you atropine, what will happen? Your people will be dilated. Okay? That is why in people who, when they are going for eye examination, they can put atropine on their eyes, and the people will be dilated for them to be able to examine. Okay? And another thing is that if I block sympathetic, then you are likely to undergo meiosis, right? All right. Does anybody have any question? So here the person ate a mushroom which contains a lot of muscarinic, and this muscarinic will stimulate the M3 receptors found on the pupillary sphincter muscle in the iris, and then it will cause what? Pupillary constriction, which is also called meiosis. Please, let's read the question, answer it, and move on. Does anybody have any question here? All right, let's move on. So the person ate mushrooms, and the muscarinic receptors, cholinol receptors were stimulated. What symptoms signalize intoxication with inedible mushroom? And the answer is going to be what? Meiotic people. Okay? Meiotic peoples. All right. So, Bright, read question number 131 for us.
Question 131. A patient who suffers from insomnia caused by emotional disorder was prescribed a hypnotic drug with tranquilizing effect. What hypnotic was prescribed?
All right. So listen. Insomnia basically means you are not able to sleep. Okay? Sleeplessness. Okay? So let's just imagine this is the brain, right? Now, in the brain, there are a lot of impulses coming. And those impulses These impulses, which are coming from the spinal cord, okay, should reach what we call consciousness. So it should reach to the what? The cerebral cortex before you feel that whatever is happening. Now, however, there is a wakefulness center in our brain, okay? And that wakefulness center passing through the anterior part of the hypothalamus. What happens is that once we are awake like this, it keeps on firing impulse to let us feel awake. So in people who are having sleeplessness, it means that those impulses are still coming from the anterior part of the hypothalamus. So this part here is the anterior part, okay? It keeps on firing impulse to the cerebral cortex to let us feel awake. However, when we are about sleeping, okay, normally GABA binds to receptors on a cell, those cells over there. And once GABA binds to those, so just imagine these are the cells that keep on firing the impulse. So once GABA binds to those cells, okay, once GABA binds to those cells, GABA will bind here. It will allow what? Chloride ions to come in. And once chloride ions comes in, what happens? This cell will undergo hyperpolarization. And once hyperpolarization has been reached, it will be difficult to reach threshold firing of impulse. Okay, so that is how we sleep. But those people who are having less GABA, or maybe the GABA is binding, but very few chloride ions are going in, we can give a drug that will enhance the binding of GABA. Okay, so there is another side which we call the benzodiazepine receptors, okay, which helps in GABA A receptors. The GABA, we have GABA A and GABA B, okay? So once they bind there, what they do is that they increases the affinity of GABA to each receptor. So now more GABA can, once you bring benzodiazepines like diazepam, nitrazepam, they bind to a part of that same ion channel and then increases the affinity of GABA to each receptor on that channel. Once they increase the affinity like that, more GABA can now bind there and more chloride ions can now come inside. And then it will stop the firing of impulse and then the person can sleep, okay? So in insomnia, okay, it's not only in insomnia, even when there is action potential, a lot of impulses getting to the cerebral cortex, it's still the benzodiazepines that you use, okay? So in people who are having insomnia and people who are having anxiety disorders and seizures, you give these kind of benzodiazepines. So they will bind to those benzodiazepine receptors found on the ion channels of GABA A receptor. Then they increases the affinity of GABA A to each receptor and then allow more chloride ions to get inside, okay? So this is how it functions. So example of said drugs that you can give for insomnia, which is difficulty in sleeping, to induce sleep is diazepam or nitrazepam, okay? So please read the question. Question number 32. Mr. Hippuric, please read that question for us in just a moment.
Examination of a 66-year-old patient revealed a lytic tumor in the locus of pathological rib fracture. Histologically, this tumor consists of atypical plasmoblast. Further examination revealed osteoporosis in the bones of vertebral column and pelvis. These changes are atypical for . Hello, Dr. Mo.
He said we should give him a minute. He's coming.
Okay.
Blood cells are produced from where? The bone marrow, right?
Yeah.
Yes.
So the bone marrow produce all the lineage of blood cells, okay? So being it the lymphocytes and the granulocytes. So you know we have two. We have lymphocytes, right? And we have what? Granulocytes. Granulocytes. And we also have what? So basically, let me say, we have the lymphoid lineage, okay? Lymphoid lineage, lymphoid and myeloid, okay? Myeloid. They all come from the same stem cell, okay? Stem cell. But the lymphoid lineage will give us the lymphocyte, that is the T and B lymphocytes, right? And the myeloid lineage will give us the granulocyte. It will give us what? The megakaryocyte, and it will give us what? Erythrocyte, right? Erythrocyte and megakaryocyte. And then the A granulocyte, sorry, A granulocyte. So the megakaryocyte will eventually become what? Platelets, okay? So A granulocytes will give us the monocytes, okay, which will give us macrophages, right? The granulocytes will give us the neutrophils, the eosinophils, and the basophils, or the mast cells. Then the erythroid lineage will give us the red blood cells, okay? So they're all coming from the myeloid. And the lymphoid ones will give us T lymphocytes and then B lymphocyte. They will migrate, usually the T lymphocyte will migrate to the thymus to undergo differentiation and stuff like that. So the B lymphocyte will still remain inside the bone marrow. But the B lymphocytes, okay, will still undergo maturation and everything in the bone marrow. So once it is activated, it forms what we call, it will still remain in the what? Bone marrow. Once it is activated, it will form what we call the plasma cells, okay? But the primitive ones are called plasmoblasts, okay? The smaller, the immature ones are called plasmoblasts. These plasma cells, they are responsible for what? Manufacturing what? They are responsible for manufacturing what?
Antibodies.
Thank you very much. Antibodies. Now,
the board is clear.
The board is clear. Sorry. Is it clearer now?
Sure.
All right. However, there are instances where you see the stem cell, we have the lymphoid cells, the myeloid cells, but there are instances where one of the lineages may start dividing abnormally, okay? And then they will start using up all the nutrients and the space and everything to keep on dividing. So in a situation where we have either the B cell or the B lymphocyte or the 8 plasma cells dividing more, okay, we call that process what? Myelomatosis. Okay, myelomatosis. Now, we call it multiple myeloma when there are multiple bone marrow in which there is excess production of what? Plasma cells. Okay, and we can call it plasmacytoma, plasmacytoma. Okay, when it is found, plasmacytoma, when it is found in one cell, but it is forming like a tumor. But because they are happening in the bone marrow, okay, because they are happening in the bone marrow, these plasma cells will keep on dividing. It will keep on dividing so much that it will start compressing on the bone marrow to start what? Degenerating it, okay? It will start degenerating it. It wants enough space to keep on dividing, okay? So it will keep on degenerating it, and it will make the bone weak and it can break. Okay, so once it makes the bone weak like that, we call it, it is lysing it. Okay, it is just lysing it. So if you view this kind of bones under this thing under X-ray, you see that the density of the bone has reduced, and there are a lot of what lucencies, dark areas, okay, in the bone. Ideally, bone, because of the calcium, it has what it does is that it absorbs a lot of the X-ray, so that it doesn't allow the X-ray to go through it to make the film dark. So normally bones are white, but with the development of multiple myeloma or myelomatosis, some of the areas become what? Broken, and it allows some of the X-rays to pass through it. That is why you see some lucencies on the bone. Okay? On the X-ray, rather. On the X-ray. So, it is the plasma, you see, and the funny thing is that because these plasma cells, what is happening is that once they keep on dividing, even though some will spill over into the blood, okay, and they will keep on producing abnormal proteins, which we call the paraproteins, and some will be secreted in the urine as Benz-Jones proteins. But when it is found, it is confined in a bone, forming the plasmacytoma, then they cause excessive damage to that bone, okay? Does anybody have any questions? So basically, the multiple myeloma will lead to excessive plasma cell production in the bone marrow, and it will destroy the bone. Okay, so let's move on to the next question, please. Please, can you project the question? So the answer is going to be, please, we didn't see the question, the answer, because I don't know whether it is myelomatosis. So please, the question number 132 again, let it move up a bit, and let's see, 132. Question number 132. Can you please let us see that question again? So they said a 60-year-old examination revealed latent tumor in the locus of pathological rib fracture. Okay, and when they did histological examination, they found out that there is an atypical plasmoblast. So the moment you see atypical, you think of cancer, right? So further examination revealed osteoporosis in the bones of the vertebral column. It means that there are multiple bones involved. So we call it multiple myeloma. So the answer is going to be what? Myelomatosis, okay? So let's move on to question number 133. And James, I'll read that question for us.
A 46-year-old patient who had been suffering from tuberculosis for 6 years died from massive pulmonary hemorrhage. Autopsy revealed different 6 foci of sclerosis and caseous necrosis in lungs. In the upper part of the right lung, there was a cavity 5 centimeters in diameter with dense gray walls. The cavity contained liquid blood and blood clots. What type of tuberculosis is it?
Now listen. Sometimes these kind of questions can be tricky, okay? But see, the moment they talk about tuberculosis, okay, first of all, once they mention the age and the person's age is above the 20s, you think of what? Secondary tuberculosis. And in secondary tuberculosis, we have one that we call cavernous what? Tuberculosis. Now, this cavernous tuberculosis, there are two. So first of all, what are the key words that you have to look for? Cavity. Cavity formation. So once you see cavity formation, then you think of what? Cavernous TB. Now, you can have acute cavernous or chronic cavernous. Now, how do you differentiate between the acute and the chronic cavernous? In the chronic cavernous, the wall or the edges of the cavity is formed with fibrous connective tissue. Fibrous tissues, okay? And because of that, they are what? Dense in nature. Okay, dense. But if they are in acute, the connective tissue over there are loose, okay? And they are what? Soft in nature. So once you see that there is fibrous, dense connective tissue, then you think of what? Chronic cavernous. They say cavity formation, cavernous. But how do you differentiate between acute and chronic? In the acute, the edges are soft, okay, and the connective tissues there are loose. But here in the chronic, the edges are dense, okay? All right. And you know, it is only in the cavernous that the cavity may protrude into a vessel and it will start bleeding. So it is at this point when those people with TB will start coughing up blood, okay? Once there is cavity formation and that cavity enters into a blood vessel, the person coughs and brings out blood also. Please project the question. Let's answer it and move on. Does anybody have any question here? So you see cavity, you think of cavernous tuberculosis. Then they will describe the edges. Look for dense fibrous connective tissue if you are thinking of chronic cavernous. But if there is no dense connective tissue, think of it as acute. Please clear the question. So the answer is going to go at fibrocavernous. So normally the chronic one can also be called fibrocavernous, okay? The chronic one can also be called fibrocavernous. Let's move on to question number 134. All right, so Daniela, please read question number 134 for us. Okay, is Kathy there? Kathy, can you please read the question number 134 for us?
Yes, sir. During the repeated Vidal's agglutination test, it was noticed that the ratio of antibodies, titers, and O antigens S-typhi in the patient's serum had increased from 1:100 to 1:400. How would you interpret these results?
Okay, so please look on the board. Now, when someone is suffering from typhoid, especially in developing worlds, this condition is very common and it's caused by Salmonella typhi. Okay, Salmonella typhi. Now, this Salmonella typhi is a bacilli which is having a flagella, but we tend to produce two antibodies against the antigenic part and the flagella. Okay, this test that we are talking about is called Renal test. It's checking for antibodies. However, this test in the developing world, please, this test, you shouldn't use it to diagnose somebody, okay? If you want to confirm typhoid fever, use either blood culture and sensitivity, urine culture and sensitivity, or stool culture and sensitivity. In the developing world, we use this without test to only monitor treatment. But in the developed world, in the developing world, but in the developed world, assuming which this condition is very rare, when someone has, or even if you come to Africa, let's say, if you are not having access to this kind of laboratory testing, when someone has the typhoid, okay, or someone has had it before, this TO, okay, usually it is called 1 over some figure. If it is 1 over 20, it is not anything. This TO, which is the antigenic part, once it increases rapidly, okay, in the disease, when someone is having typhoid fever, it will increases rapidly to up to about 160 and above, okay? 1 over 160 and above. That is infectious state. Infectious what? State. So maybe someone brings the renal test and you are checking. You see TO and TH. If the TO is greater than 1 over 160 and above, the person is having the disease, okay? Infectious state. The person is having the disease. But the flagellar part, so it means that in acute phase, this one, the antibodies for this increases fast. The somatic antigen, it increases fast. But,
Dr. Mo, sorry to interrupt, but the board display.
Oh, okay, sorry. Is it clearer now?
Yes, please.
Okay now. Okay. Okay. So the TO is what we use to confirm the disease, the presence of the disease. So if the TO, if you check it and it is 1 over 160 and above, then the person is suffering from the disease. But the TH, okay, the TH here, it only tells you that this person has been previously been affected by the Salmonella typhi. So we use it to check those people who have suffered from typhoid before. Okay, so for previous infection. So for them, so assuming someone comes, then the TO is 160 and above, you think of the infection. But if the person is healing, if the person is healed from the infection, then the TH will start increasing. Okay, so this TH usually increases slowly, but the TO in an infectious state, it will increase fast. But during the healing phase, then this flagellar, the TH will start increasing. So all the time, if you want to confirm that someone is having typhoid with the radar test, look at the TO. Don't pay much attention to the TH. Pay attention to the TO. That is the somatic antigen. And if it is above 1 over 160, it confirms the diagnosis. Okay. So in the question, they said that that person's TO rose from what? 1 over 100 to what? 1 over 400. So it means the person is suffering from the condition. Okay. Please project the question and let's answer it. So the patient is, where is the answer? The patient has typhoid fever. The patient has typhoid fever. All right. Okay. So let's move on to question number 135. Okay. So Millicent, is Daniela around?
Yeah.
Please read question number 135 for us.
Okay. A patient complained about muscle rigidity, constrained motions, constant tremor of arms. On the grounds of examination, his disease was diagnosed as Parkinson's disease. What drug should be administered?
All right. So please look at something here for me. Last time I drew the midbrain like this, and I told you that we have a structure here. Okay, we call it what? Basal gang. This one, sorry, this one is the substantia nigra. Substantia nigra. Nigra is black. Substantia is substance. So black substance, right? Now, I remember we spoke about this thing also. We spoke about the arrangement of coded nucleus, okay? Then we have globus pallidus, and we have putamen, okay? We have putamen. And we said there is a structure, and we have the thalami, or the thalamus, sitting here. Okay, so the same arrangement here. There is a structure like this, and there is a structure like that. Okay, and we spoke of the fact that there are some V-shaped structure here. Okay, what's the name of this V-shaped structure? This V-shaped structure, what's the name of it? Who can tell me?
Internal capsule.
Internal capsule, thank you. So these structures here, coded nucleus, putamen, globus pallidus, internal and external. These structures here form, and the thalamus, and there is a structure called subthalami, plus the substantia nigra. Together they form what we call the basal ganglia. Basal ganglia. Okay? And what they do is that they allow us to achieve a precise movement. What do I mean by that? When you want to drink water, okay, you go to the cup, you pick it, you bring it to your mouth, you drink, and you put it down, right? So, assuming maybe we don't have a center in the brain controlling this kind of simple movement. You want to drink water, then instead of you going to the cup, you move your hand and you slap somebody, or maybe you hold the cup, and instead of bringing it to your mouth, your hands will be shaking. Okay. So that precise movement, listen, that precise smooth movement is coordinated by what we call the basal ganglia. Maybe sometime where I will take my time to explain it into details how it works. However, before that precise movement can be achieved, there is a triggering factor. Like, you know, if you've read, those who ride motorbikes, okay, the motorbike, maybe you have to step on something to kickstart the motorbike when you want to spark it, right? So there are some neurotransmitters coming from this substantia nigra into the basal ganglia. We call that neurotransmitter dopamine. Okay, dopamine. And the function of that dopamine is to help us to initiate movement. Okay, to start movement and also bring the movement to a halt. That's the function of the dopamine. And so before you can start the movement, you need the dopamine, right? And before you can stop the movement, you need the dopamine. So without the dopamine, it means it will be difficult for us to start a movement. And without the dopamine, if there is a movement going on, it is difficult to stop it. Those people who don't have the dopamine being released from the substantia nigra into the basal ganglia, they suffer from a whole lot of a condition we call Parkinson's disease, okay? And it is usually characterized by muscle rigidity, okay? Muscle rigidity, tremors, hypokinesia. Hypokinesia, think of it like difficulty in initiating movement, okay? So if you have these three things in mind, Okay, if you see a patient, and they usually have a masked face, so they don't show any, when they are smiling, you don't know whether they are angry, you don't know. It's like they are wearing a mask, okay? So they have masked face because of that rigidity, okay? Masked face. And why are they having this condition? Because the dopamine that is supposed to move from the substantia nigra into the basal ganglia is not there. So if the dopamine is not there, they experience this. So if you are going to treat that patient, what do? You give a dopamine supplement so that dopamine can go there. And we have a drug called levodopa. Okay, you have a drug called levodopa. So if someone is having Parkinson's disease, they are lacking dopamine. So if you are lacking dopamine, you give a dopamine substitution. And a drug called levodopa does that job. Okay? Does anybody have any question? All right. If there is no question, let's move on, please. One day I'll explain the function of the basal ganglia. Okay? So the answer is going to be E, levodopa. What drug should be administered? You give levodopa. Okay? Let's move on. So question number 136. Okay, Nanaya, read that question for us.
Labeled amino acids, alanine and tryptophan, were injected into a mouse in order to study localization of protein synthesis in its cells. The labeled amino acid will be accumulated near the following organelles.
All right. So this answer, I know everybody knows. This question, I know everybody knows the answer, right? So inside the cell, we have the nucleus, and inside the nucleus, we have DNA, and inside the DNA, some part which is called a gene will be expressed, and will form another RNA called mRNA, right? mRNA. Now this mRNA will bring its sequence out, and what we call the codon, right? And once it comes into the cytoplasm, what needs to happen? We need to read the codon to form what? A protein. And proteins are just what? A non-polypeptide chain, all right, which has undergone post-translational modification. So first, once the mRNA comes into the cytoplasm, there is this structure called ribosome, right? Ribosome or ribosomal unit. So we have the large unit and we have the small unit. It was arrange itself, okay, to assemble itself on the sequence, okay, of the mRNA, bringing that rRNA, okay, rRNA. Now there will be a tRNA, which will come and read the sequence, which is the codon, and form its own anticodon. And it will use it to bring, okay, it will use it to bring an amino acid, okay? So the amino acid will be brought here, and then it will form a growing chain, okay? So that we will have a growing chain of the amino acid. So if you give that amino acid to the patient, okay, what is going to happen is that where the ribosome has been arranged, that is where you see that amino acid being attached to that growing chain. So wherever you have ribosomes, think of it this way, that there is what? Translation going on. And because of that translation, those amino acids will be accumulated at where? The ribosomes. So this, in the cell, normally we have what we call endoplasmic reticulum. The endoplasmic reticulum, we have the smooth one and we have the rough one. On the rough one, what makes it rough is because it has what? Ribosomes there. Okay? So if you want to see exactly where this thing is going on, or the accumulation of amino acid, look at it from where the ribosomes are, or you go to the rough endoplasmic reticulum. Okay? So does anybody have any question? Else, let's move on, please. This is just a basic stuff. So the answer is going to be ribosomes. So question number 137. Mahawa, can you please read that question for us? And answer it and tell us why.
Okay. A 56-year-old patient suffering from cardiac insufficiency has edema of feet and shins. Endematous skin is pale and cold. What is the leading mechanism of endemata pathogenesis? So the answer is rise of the hydrostatic pressure in the venous, because when there's an increase in the hydrostatic pressure, it pushes out more water from within the vessels. So then it will lead to edema.
Okay, so why was the hydrostatic pressure increased?
Because of cardiac insufficiency.
So cardiac insufficiency, what happened? So the heart wasn't able to pump blood into the forward direction, that is in general circulation. So the venous return was coming, it kept on coming, and there was a backlog, right? So let me just draw something simple here, okay? And you get a better understanding. So this is the heart, right? Ideally, the heart blood is coming from the venous, the veins, and the vena cava, right? And the blood is coming this way, right? From this direction. Then it has to move from here to here, right? Then eventually pass through the pulmonary trunk, then get back here, right? And then move into the left ventricle. Then the left ventricle will pump it through the aortic valve, then go through general circulation again, right? And in the general circulation, they will be part of they will pass through the artery. So if the blood is returning, but when it gets here, it is only small amount that is being pumped forward. What will happen? It means that the blood that is coming, first it will start building up. Okay, so if this left heart pumps, assuming it receives 100 mils, and is only able to pump 50. 50 is left, right? So 100 comes, and now it becomes what? 150. It only pumps 50, and now it will be 100, right? Because 50, listen, first it received 50, it pumped, then 50 was left because only 50 went away. Now new 100 will come. Still, it can only pump 50. So 100 will come, 50 has been pumped, then it will now be 100 mils to be left here. Now new 100 will come, 50 will be pumped, then what will be left behind? 150. So as it is leaving behind like that, it keeps on building backwards. Okay, it keeps on building backwards. So there is accumulation of the blood, and it will keep on building backwards, and it will keep on building backwards into the venule end of the capillary. What is building? The blood, the volume of the blood is increasing, and it is increasing backwards. And whilst it increases backwards, the venule end will start experiencing the increase because the forward movement of the blood is not happening, but the returning of the blood to the heart is still happening. So there is what? Backflow. And hydrostatic pressure will increase because hydrostatic pressure is determined by what? The volume of the blood, right? So that is why ideally hydrostatic pressure was supposed to have decreased, right? So here it should have been 33 here, and here by the time it gets here, it should be 15. But because there is backlog, it will still increase to up to 33, right? So your answer is right. Why the increase in hydrostatic pressure? Because the heart wasn't able to pump blood into the forward direction or into general circulation. So there is a what? A backlog, okay? All right, so let's move on. I believe everybody understands this concept, okay? So let's move on. So question number 128. Monica, read it for us. 138 rather, 138. Monica, please read it for us.
Yes, sir. A 50-year-old man who was referred to the hospital for treatment of cervical lymphadenitis underwent test for individual sensitivity to penicillin. 30 seconds after, he went to hot all over. AP drop, action potential drops down to 0 mmHg. That leads to cardiac arrest. Resuscitation was unsuccessful. Autopsy results: acute nervous plethora of internal organs. Histological examination of skin from the site of injection revealed degranulation of mast cells, that is tissue basophils. Degranulation was also revealed in myocardium and lungs. What type of hypersensitivity reaction is it?
All right. So here they said that the patient had arterial blood pressure to be dropped, and then patient was having cardiac arrest. Resuscitation was unsuccessful, so the patient died, right? So let's see what happened. Remember, so bigger screen, please. Remember we spoke about hypersensitivity, and we said that hypersensitivity is an exaggerated form of immune response to a foreign organism that ends up to damage our self or our our own self. Okay, so we said we have type 1 hypersensitivity, which is also called the immediate. Okay, immediate or atopy sensitivity is the immediate form, or sometimes call it atopy, or we call it anaphylaxis. Okay, so anaphylaxis is actually an example of the type 1 hypersensitivity. So what happened is that there is always production of immunoglobulin E. Okay, immunoglobulin E sitting on the membrane of the mast cells or basophils. Why? Because there was an initial introduction of that microorganism that led to, or an allergen that led to the production of this immunoglobulin E. And once they sit on the basement membrane, once there is reintroduction of that same mechanism. So for instance, the penicillin, okay? This patient was given penicillin, probably before. It's two ways. It's either the patient had been given penicillin before, and once the first time they gave the penicillin was seen by the macrophage as foreign organism. So the macrophage engulfed it, okay? And once the macrophage started digesting the penicillin, it couldn't digest it all. So it presented the antigenic part of the penicillin to the T helper cell. So the T helper cell activated T helper 2, and then it also went ahead to activate the B cells. Then the B cells also led to the production of plasma cells, which only produces immunoglobulin E. And that immunoglobulin E is able to bind to this particular antigen. So this immunoglobulin E, once they were produced, they went and bound to the membrane of mast cells and basophils found in the connective tissues and the blood, okay, respectively. So once they sit there, whenever there is reintroduction of this penicillin, it will not go through this whole process. The immunoglobulin E will just directly bind to those, what do we call it? Penicillin. And once they bind to it, their FC portion, the top part, okay, will shake, and then there will be degranulation. Okay, those degranulation, you know, inside the mast cell, they have what? Vesicles which contains histamine. Not only histamine, they contain serotonin, they contain bradykinin and other stuff. But histamine is the most important thing you should understand. So this histamine will be released into the blood. Now, one function of histamine is that they cause vasodilation. So they will cause the vessels to dilate. Okay? So once they cause the vessels to dilate, you know the blood vessel, what the part of the blood vessel which actually maintains normal blood pressure is the ones with the peripheral resistance. So the arterioles, okay, the arterioles which is having smooth muscles around it, okay, they exert peripheral resistance and they help maintain the blood pressure. So assuming this muscle is found over there, what they will do is that they will cause the smooth muscle to relax, okay? And once they cause the smooth muscle to relax, that peripheral resistance maintaining the blood pressure will not be there. And what will happen is that there will be peripheral pooling of the blood and the blood pressure will drop, okay? The blood pressure will drop because there is excessive vasodilation, especially at the peripheral resistant vessels. Okay? Apart from that, what is going to happen? The histamine will cause, so histamine will cause what? Vasodilation. Vasodilation leading to what? Drop in blood pressure. They also increase permeability. Okay? So they will increase permeability of the vessel. That will also cause what? Some edemas. And sometimes in some people, you know, this histamine can stimulate goblet cells to produce a lot of mucus. And then once they stimulate those goblet cells, they can also lead to vasoconstriction, bronchoconstrictions. Okay? Bronchoconstrictions. So the most dangerous aspect of it all is the drop in pressure. And once that pressure drops so much, it leads to what we call shock. Okay? Severe hypoperfusion of all the organs, okay? All the vital organs. And that may lead to death, okay? That may also lead to death. All right. So it is the type 1 hypersensitivity. An example is what? Anaphylaxis. Even people with asthma, they still undergo through this type 1 hypersensitivity. Atopy and stuff like that. And those rhinitis. But whenever there is sudden drop of blood pressure, okay, it means that the basophils found in the, you know, basophils are found in our blood. So there is generalized release or degranulation of the basophils or the mast cells. Okay, they are almost the same, just that different, where they find themselves gives them the different name. So when there is generalized degranulation, then they will cause vasodilation and they will lead to what? Shock. And that kind of shock is called anaphylactic shock. And that kind of anaphylactic shock can lead to death, okay, if the appropriate measurement is not taken. So please take this home. I've seen a child who died of anaphylactic shock before. When I was practicing, in my early years of practicing, we gave this child what we call X-pen. Okay, it's the crystalline penicillin. And the moment I turned myself, this child started having difficulty in breathing. And then all of a sudden, this child popped off. The child died. And I was the one who gave the drug. Then I didn't even know about anaphylaxis. Okay, it is common with penicillin and some other drugs, and even bee sting. Okay, so the ideal way of managing this case was, first of all, I should have the appropriate knowledge of anaphylactic shock. In some scenarios, this patient will have generalized itchy rash or some wheals. Okay, and then they will have difficulty in breathing and they will be wheezing. Wheezing, like you hear some sound like fin, fin. And then when you measure or when you check peripheral pulse, it will be rapid, it will be increased, okay? But then when it measures the pressure, it will be very low. The rapid pulse will be steady. You will not feel it that much. So once you give someone a medication, or maybe they rush a patient to the hospital and you see these signs, please think of anaphylaxis. And the appropriate management is that you first will have to get the person adrenaline. Remember, adrenaline will bind to the smooth muscles and cause vasoconstriction, right? They also increase the heart rate. Remember, they will increase the conduction, the heart rate, and then pumping ability of the heart. Again, they will help dilate the bronchus. I will explain that one later. And again, you can give this drug we call promethazine. This promethazine drug is, what do we call it? Antihistamine. But first of all, the BP is dropping, so you have to set an IV line. Whilst you are giving the adrenaline and promethazine, you still have to give fluid, okay? To make sure that you compensate for maybe if there has been a third tracing, that is fluid moving out of the vessels into interstitial spaces, all right? So in anaphylaxis, we give what? Adrenaline, promethazine, then you give, if the person is having still bronchoconstriction, you can give salbutamol. You have to set an IV line to run the infusion fast. Any infusion that you have, at that time, you don't think of whether it is normal saline or Rendes or whatever. Any infusion that you get, you lay your hands on, set it up and run it, okay? Then you may be likely to save the patient. So please keep it in mind. It is a common condition that may happen at any time. All right. So the answer is anaphylactic. And this patient, unfortunately, they couldn't save, okay? Let's move on to question number 139. All right. So, Bright, please read that question for us. Is Bright there?
139.
Mm-hmm.
During examination of a patient, a dentist revealed a lot of white spot zones on the enamel in enamel demineralization. What microorganism takes part in the development of this process?
Okay, so in our mouth, there is, we have normal bacteria resident in every part of our body, and we call them normal flora. Okay, so in our mouth, we have one of those bacteria resident in our mouth, and we call it Streptococcus mutans. Ideally, these Streptococcus mutans, what they were not supposed to cause any disease, but later they realized that it was playing an important role in tooth decay. How? So you take in fruit, right? And the sugar of fruit is called what? Sucrose. Or you take any sugary food, right? And it contains sucrose. So this sucrose, that is what the Streptococcus mutans like. What they will do is that they will break the sucrose down into what? Glucose and fructose. And then they will use this fructose to form lactic acid. So for those people who don't usually brush their teeth, who have poor oral hygiene, these Streptococcus mutans are usually found in the plaque that is found in between the teeth. Once the person does not brush for a while. So once they are there, that is when they can act effectively on the fructose and convert it into lactic acid. And once they convert it into lactic acid, it helps in the dissolution of the hard enamel. The enamel that was so hard because it has been mineralized very well. And then they will lead to demineralization of it, and it will lead to tooth decay. So it is the Streptococcus mutans that do that, and with the help of converting fructose to lactic acid. So the answer is going to be Streptococcus mutans. Please, let's move on to question number 140. All right, so James, 140 is yours.
Thank you for the privilege. A patient who was been abusing tobacco smoking for a long time has got cough accompanied by excretion of viscous mucus. Weakness after minor physical stress, pale skin. The patient has also lost 12.0 kilograms of body weight. Endoscopy examination of biopsy material, his illness was diagnosed as squamous cell carcinoma, named a pathological process that preceded formation of the tumor.
So they did endoscopic what? Examination of biopsy material in his, they diagnosed him of what? Squamous cell carcinoma. Now, normally in the bronchus, right, the cells over there, they are what? Some are columnar in shape, okay, like rectangular, okay, and some are what? Cuboidal. So they look like cubes, okay? And most of them are goblet cells, right? They are goblet cells. So the goblet cells are there to produce the mucus in between those normal cells. However, these cells, some of them are ciliated. But when a cell changes from one form, so either from columnar, so you see their normal forms are columnar. So let me draw something on the board, please. Give me a bigger screen and let me draw something here. And let's use it to summarize for today. All right, so in the lungs or in the bronchus, these are the way that the cells looks like, okay? Sometimes they are ciliated. Yeah, this is what we call columnar, okay? Columnar cells. The cuboidal cells, they are having all sides to be equal. So sometimes some of them are cuboidal. But they are saying this patient, once they took a biopsy, they realized that they are flat cells. These flat cells are squamous. So this one is called columnar. This one is called cuboidal. Okay? And these kind of cells are called squamous. Okay. Now listen. When we talk about metaplasia, it means that this cell, wherever you are taking the cell sample from, I believe the cell sample was, if that cell over the resident cells are columnar, if they change from columnar to cuboidal, we say it is metaplasia. Or if they change from columnar to squamous, we say it's metaplasia. Or vice versa. If the normal cell over there is squamous and it changed from the squamous form to cuboidal or to columnar form, we say it is metaplasia. So metaplasia means change in cell form. Okay? So how do you know it is metaplasia? It means you need to know each and every tissue, the kind of cells found over there, right? So if you go to your bladder, you have some cells, we call them transitional cells, right? And one thing, the commonest way of identifying cells is that squamous cells are usually found in areas in our body that is exposed to air. Usually, they are found in areas that are exposed to air. And those areas, they are keratinized. Do you understand it? Now, the areas that are not constantly exposed to air but still are squamous, that are still squamous, are non-keratinized ones. Like if you open your mouth, okay, the buccal cavity. In your buccal cavity, you can have non-keratinized squamous cell. On our skin, we have keratinized squamous cell. Okay, so they are the flat cells. Now, mucus secreting areas, okay, in our body usually have what? Columnar cells and sometimes cuboidal cells, okay? So we have columnar cells in our bronchus, we have columnar cells in our GI tract, we have columnar cells in our, let's say, fallopian tubes, you understand, and cuboidals. So in a simple terms, just think of it that way. I mean, it's not that difficult. So wherever there is some secretions like mucus coming from, think of it that there are columnar cells. Now, in a place where it stretches, okay, if there is an area in your body that stretches, like the bladder stretches, right? Most of the times the cells over there are called transitional cells. So what it means is that you see the cell, it looks like columnar, but as the bladder keeps on filling with urine, it changes to squamous. But once it becomes empty again, it comes back to columnar. So it transits from columnar shape to squamous, depending on the filling ability of the bladder. And you see all the adjacent structures to the bladder too, some of them do have transitional cells, like the urethra and the ureter. The ones close to the parts that are close to the bladder. So once there is change of forms of one cell form to the other, we call it metaplasia. All right. Is there any other question for me today? Is there any question? I hope you enjoyed today's class. And this brings us to the end of today's class. We'll meet again on when? Tuesday, right?
Yes, Tuesday.
Yeah, tomorrow is election day in Ghana. So we are going to vote.